I should be playing some Empire Strikes Back music when the lawyer gets up here. Sometimes feel like that even among my own colleagues, but any lawyers in here besides me? That right there should tell you something about informed consent. And, I mean, this conversation has been fantastic, but I think part of it, and one of the things that some of you, Steve Rush and some of the other folks in here have heard me speak about a lot is change. I'm really an instrument of change. And that's one of the things we need to do. And not only do we need to discuss or create change in the informed consent process, but we also need to change mindsets, of the physicians, of patients perhaps a little bit, but also of the lawyers that you all have to work with that approve of these new processes, of these new forms or whatever. Michael's organization is great because he gets to do what he wants to do. He's the one who runs it. But not everybody's as lucky to have that. So that's kind of what I'm here today to talk about, is a little bit about creating this harmony. I created the title for the planning group, but then I changed it to creating instead of creating harmony between the law and health literacy. But anyhow, so that's really what I kind of thought as my task for this group was to really think about the form process, because everybody else was set up with talking about the how can we redesign the communication process. And that's what I thought about, is how can we create a form that enhances everything else that you all have been saying and that you will say after me. How can you promote this conversation with the form? And as everybody, and I'll talk a little bit more about this in a few minutes, but where does the form come into the process? It's later on in the process, but the process has to begin earlier. But anyhow, this was my goal, my self-appointed goal, was to create or recreate a form that actually promotes these health literacy principles and promotes this conversation between patient and provider. So I'm sticking with procedures here instead of clinical trials, just because it's a little bit easier. There are fewer rules and regulations. I mean, I guess there are more if you count the 50 states, but not as many hoops to jump through. And most of these state-based regulations are based on the common law principles that Dr. Sugarman talked about earlier. That kind of developed in the early 20th century. So this is, I think, the easier way to break into the field and break the mold, and then we can keep working on other more more clinical trials and other things of that nature. So what needs to be disclosed in a consent form? Generally, again, I mean, every state has slightly different requirements, but always the risks and the alternatives, a description of the procedure, patient's consent. You're always going to have these things, and then other legal disclosures that are required by the individual states. You might, or the individual types of procedures, like with HIV and various other things. So these are our limitations, but when we talk to our legal counsel, it seems like these are mandates, and the words that we use have to be mandated by our state laws. That's not true. These topics need to be covered, but the language we use is usually not covered by the law. Occasionally you will have, you must say this in conspicuous language or something like that, but that's rare, but even though lawyers treat that as the norm, which is really not the case. So, as Dr. Sugarman was saying earlier today, there are two standards. He really talked about a third standard, but really two main standards in terms of how, let's say there's a problem and somebody wants to sue over lack of informed consent or failure to get the right type of consent. There's a reasonable physician standard, or it's also called the professional custom standard, and then there's also the reasonable patient standard. About 23 states use the reasonable physician standard, including my own state of Michigan. The reasonable patient standards, I think, in 25 states, and including DC, and then Tennessee uses more of a intentional tort standard, which so it's a little bit different. A couple other hybrids, basically. But the theory with this is, the reasonable physician standard is that what is the prevailing practice among physicians in your locality or your community. And then the reasonable patient standard is what it sounds like. What would a reasonable person, not the person themselves, but what would a reasonable patient understand? Now, that's a legal creation. right? Because what's reasonable to some sitting judge or to lawyers is not what's reasonable to patients, as we all know. And one of the things to think about, I think, is how this came about. That was the great thing about the first presentation of the day, is it started in the 1908 range. Well, we didn't have all of this information about patient literacy and patient understanding at that time. It's a thing of the recent past couple of decades, maybe 15, 20 years or so. So how does health literacy fit within these legal standards? It doesn't. Some of my research is focused on trying to find cases where people have argued that lack of health literacy and understanding should lower the standard. I haven't really found anything just like that. There's about 3 or 4 cases that kind of deal with the patient not understanding something because they couldn't read or whatever. But it's very, very minor is the point. So I think from an advocacy perspective, and I'll talk more about this perhaps later at dinner or in conversations or something like this, how do we promote this and how do we make this change? Well, I think it'll be a little easier with the patient standard. The patient standard, the way that we get companies to change, the way that we get lawyers to change, or we get the lawyers in your companies to change, is threatened lawsuits, or actual lawsuits would be even better. But if that happens, the argument needs to be, look at all the research we've done over the last 15 to 20 years. The reasonable patient is not what your case law currently says. It's this person with a 6th grade education that doesn't quite understand what they're talking about. We can even use some of the research, with the various patient segments that was talked about earlier today. That is something that I think could really take hold. But I've yet to find anybody make that argument. Now, from the reasonable or physician standard or the custom standard, this is where groups like this, the IOM, the AMA, all of the major groups, if health literacy starts becoming the standard and they're promoting the standard, then that gives another argument for lawyers who are then suing over lack of informed consent, to make the argument in the reasonable physician states that, hey, look at our standards from the AMA suggest this. You didn't do it, so you should be liable. Once we get one liable case, everybody starts to change their forms and get on board with us, which is really what we want. Unfortunately, for that one doctor or hospital that has to bear the brunt of that. But what can we do now? That's more of an advocacy thing. That's a long generational change to truly get those things, to truly see a widespread change. But we can do things now to increase, from a legal perspective anyway, this idea of informed consent from a, that benefits everybody. The lawyers, but it also benefits the physicians, it also benefits the patients. These are not mutually exclusive things, the law and health literacy, even though lawyers sometimes tend to think that they are. And frankly, it's because most lawyers don't know what health literacy is. And that's where some of the advocacy comes into play. So you pull up any type of form online, you're likely to find something that's not that easy to understand. So I chose, I'll talk about a consent form that I redrafted for a colonoscopy, but I figured let's just pick one area that's procedural, that's not emergent, it's not an emergency situation, you have to prepare for it, so there's time, and it's something that we can start with, and then we can develop processes for other procedures. But I'm trying to minimize all of the lawyer's arguments for not doing this, and that's basically why I chose this. So anyhow, so I did a random search for informed consent forms. Here's one of them that came up. This was about the 11th grade level. I think it was 11.2. All of these 3 that I'm going to show you were around that same level. Not horrible, but still not great. So you see this, and you'll see 2 of these are very much alike. So probably what happened is the lawyer found this in some standard form, LegalZoom type thing, and then just adopted it for this practice's. For this practice. But there's a lot of problems with the writing. I mean, not only plain language, but just in general, just problems with the writing. So you think coagulation, an injection. Do you really need to use these medical terms with our patients? I understand the procedure involves the following: passage of digital optical instrument So digital optical instrument, does that mean your finger? Or does that mean, something that takes pictures? So a lot of problems there. Through the rectum to allow the physician to visualize their interior of my large intestine. So some of that's not bad. It's just not consistent. Sedation and pain relieving medications. Now I'm a plain language guy, and I hate the parens S. But why do you put a parens S at the end of this one and not after this one? I have no idea. But the point I want you to see from all of these errors in this one document is not just that it's difficult to understand, but that lawyers are not good at this. We are good at protecting our clients from liability. We're not good at document design. We're not good at thinking about how the impact of language on the patients and on others. We're just good at protecting our clients. That's what we're taught. And/or. I love the and/or. Actually, no, because Wisconsin case from 1935 suggested that and/or is one of those constructions that inherently creates ambiguity. It's a verbal monstrosity, as that court suggests. So usually it's and or. It's just pick one. But then I think, why do you put who in the heck would put risks here and not put headings after anything else? I have no idea. Then you have polyps. I might not know what a polyps is. But think about how, all right, now I'm messing this up. All right, I'm going to jump back, and then it'll help me do it again. But look at how they talk about risks. 5 to 10% of the time, rate of 1 per 1,000, 1% of the time. So they're jumping back and forth. So maybe you might not understand percentages, but you would understand 1 per 1,000. But then, just in case you didn't, I'm going to jump back to the 1% of the time. So we're not very good at this, is the idea. And then finally, the other thing I think about is normally this document is using I, which is fine. That's what we promote from a plain language perspective, is using the first person. But now in the same paragraph, it switched to if you have any questions. So it's switching voices, which is never good. Plus in the same paragraph. I'm also not a huge fan of the all caps here, because what that means is that you're not going to see this last line. You're just going to look at this. So you want to break that out. But anyhow, this is a pretty bad form. And here's another one that's much like it. The his, her, that's an annoyance of mine too. How much time does it take to put or in there? Or her. It's like 2 more characters, no big deal. Put that in there. But anyhow, so you read this, I understand this procedure involves such and such. But in the same paragraph, they move into, I understand that within the anesthesic sedation, that with the anesthesia sedation for this procedure, I will not be able to drive. So when you bury something in the middle like that, it's less likely to be seen. So if you want to draw eyes to it, you have to break it out. So I wasn't a fan of that. And you can see the same structure here, the risks and the 1 per 1,000. This was pretty much copied from the other one, except for some slight changes. And then the third one was the worst of the bunch, in my opinion. Just show you the carelessness that many lawyers use when drafting forms, and that nobody questions them is the other problem in this. This is the unspoken problem, except I just spoke it. So there it is. The comma, and there needs to be a comma here. That's why I put that, to remind myself. You put a comma there, you have to put a comma there. That's just something you have to do. It's something that's not intrusive. So anyhow, you have to put the comma there. So I didn't like that. That got me right off the bat. But anyhow, look at all of this description of the procedure. If an abnormality is seen or suspected, a small portion of tissue may be removed for microscopic study, or the lining may be brushed and washed with a solution that can be sent for analysis of abnormal cells, cytology. I mean, do you really need to put that in there according to the law? No, that may be what's happening, but you don't need to put that in there. Small growths can frequently be completely removed, a polyeptic, whatever. See, I'm not a doctor. I don't even know how to say it, so I just read over it. Occasionally, during the examination, a narrowed portion of stricture will be stretched to a more normal size, dilation. And now I think, okay, the principal risks of these procedures. I kind of like, using headings like that, but then I think, why do you have a heading on the left side of this, and then everything else, every other heading's in the middle? I don't understand it. And this one truly isn't centered. You probably can't see it on the Prezi, but it's not truly centered in the page. And then you can notice this. Well, here's a line, and this one has one space, and this one has two spaces, and this one has no spaces. I mean, so the point of all this is to realize that lawyers don't think about these type of things. They don't think about patient understanding, about drafting a clear form. They just draft a form that's going to comply with the state's regulation. And there's no alternatives listed in this form, and it may be the case that that's not required in this particular state, and I can't remember where this particular state was from since I redacted the other, the information on there, but anyhow, not very good forms. That's the gist. So what can we do, again, to create a form that kind of complies with the principles that everybody has been talking about today? That's what I really want to focus on now. So, like everybody's been talking about, the process is really important. We have to understand where this form fits into the process. It's not the end-all, be-all of the process, as everybody has mentioned today. It's just one cog or one step in the process. Now, ideally, for a colonoscopy, let's think about colonoscopies anyway. We don't like to think about it, but we will for now. You're getting about 50, or you have a family history, and your provider, family care physicians, talks about, well, you might need this colonoscopy now that you're turning 50 or whatever it might be. And then hopefully you're discussing it with the doctor at that point in time, but usually you may not be. Okay, I guess I have to do that. I'm 50. I've been worried about it for 5 years or something like that. But hopefully there would be a conversation at that point. And so where you might have some initial observations or questions or ways around it. Can I just push it off a couple more years? No, you can't. That type of thing. But then you'll hopefully receive some patient education. So this is where I think it's not just the form. You don't just give somebody a form, when they show up for the procedure and then have them read it and sign it. This is where all of the patient education forms that Michael has been creating, that the online tutorials that I think will be talked about after my talk here. The patient education will take place. So they're getting the initial information, hopefully in that discussion with the doctor. But even if they don't get that discussion with the doctor in that first step, they'll get a little bit more information and time to sift through it and let it sink in this educational process. So I'm not redrafting the educational forms at this point, but that's something that needs to be done, obviously, and that's something where a lot of folks are doing that because there's a financial incentive for them to do that because their companies can sell it and that type of thing. Then the patient preps for the procedure, right? Before you undertake a prep like this, the prep itself, again, is one of the difficult things. So hopefully you've thought about things, but a lot of times that doesn't happen. Then you go to the appointment, and again, this is the problem with if you just rely on the form, is once you prep, you're going to sign the form. You've already prepped. Nobody wants to go through that again. So you go to the appointment, and then you probably receive the consent form. Hopefully, you at least receive it when you walk in and you sign in, and so you have some time to digest it. And then the ideal way of doing that would be then having some type of teach back that happens before you undergo the actual procedure, kind of like a recap of all of the education that you've done, instead of just a recap of what's on the form that you just read 10 or 15 minutes ago, but what's your understanding of this process? It might just be something like, I hate the prep. I never want to go through that again, but I probably will be in 5 years. But that's part of it. So it's understanding where it falls in the process. And then creating, did it go dark on me? I don't know, it must have went dark on me. But anyhow, you can see it anyway. Create clear content. So that's incorporating a lot of the principles that have been shown to work in the studies, the teach back, numeracy skills, plain language, all of those things. And realize that you're not going to be able to get a form passed through your legal department unless you have the legal content in there, right? You've got to have the risks, the alternatives, the consent, any other thing that is really that is germane to your particular practice area or whatever you're doing. But then also the design strategy. Nothing suggests in any type of regulation that it has to look a certain way. So the way that you set things out, whether you use visuals or whether you use a lot more white space and the size of the font and all that, that's all subject to you, to your discretion or your organization's discretion. And that's where I don't think the lawyers really appreciate how just the way that we set things out really makes a difference, and it makes a difference in whether people want to even read something. So for a colonoscopy, you really think, well, it's probably limited to 2 pages. Maybe in higher risk situations, we throw the 2-page limit to the wayside because we just need more space to kind of convey the information. But in a colonoscopy, I think we could fit it all into 2 pages. But then you'll also need space for administrative needs, your office needs, and then signature lines. And if your state requires witness lines, then you need a witness line and all that. So there's other things that are going to take up this space. So with that in mind, I looked at all the consent forms, and I researched what's required, at least in my state, and I created a couple of versions, actually, which you have in your packets of a consent form for a colonoscopy. In this first form, it's front and back. It's front and back. Both of these forms incorporate teach back. The first one is the one I created first, basically. And I don't really like the first page. It seems too dense, too much information on it. So I created the second version just a few days ago because I was sitting there stewing on it, thinking about how could we create more white space so it's more inviting. And that's the point that I wanted to make with that process, is that too often lawyers, they think about how, they need to get this job done. They don't really think about how often these are going to be used, and they don't consider the design perspective of it. They don't teach that in law school, how do you design a document. I talk about it a little bit in my contract drafting course, but, I don't have much time to do more than an hour on it. So anyhow, here is the idea. Notice the requirements. What is a colonoscopy? Now this is kind of just a simplified explanation. Hopefully, this is not the first time they're learning about what a colonoscopy is, right? This is later in the process. That's the whole point of this. And I tried to keep with that. This one, I think, comes in at about a 7.8 grade level, even though I'm not a huge fan of grade levels, because just by using the word colonoscope and colonoscopy, it increases the grade level. I'm more of a fan of user design, but that's something that I can talk about for hours, or user testing, I should say. User testing to see what problem areas that patients actually run into when they're reading the document. But anyhow, your medical provider will use an instrument called the colonoscope to look at the inside lining of your bowel. I mean, if people have a problem with bowel and they want to say colon, or they want it, insides or whatever, I'm fine with different word choices there. Your provider will start from your rectum. Now, I had a really fun time a couple of weeks ago just randomly talking to people at my law school. What would you rather have? Would you rather have anus or rectum or behind or butt or whatever? On what to include, and it was pretty much evenly split. But I don't think rectum is necessarily the most understandable term for somebody with a 6th or 7th grade education. But I leave it at that for now because I couldn't figure out a way to fit butt in there without reducing the quality of the document. But maybe that's where a doctor can come in. This is what's going to happen. You're just going to go in the behind. And look at your large bowel. This is done to see if there are any problems with your bowel, such as cancers. Now notice, I don't even use the word polyps here. Growths that could turn into cancer. Because again, polyps, hopefully that's been explained before, but nature of the way things are, that's probably, the ideal process is not going to happen, or other medical problems. Now, provider, in my state, a physician can only do these, not PAs or nurse practitioners. I'm not sure what it is in other states. So we could switch this to doctor or physician, or what, probably doctor if we're going to switch it anyway. May use this instrument to remove any growths found or to remove small pieces of your bowel for testing. Will I need drugs? So that was the idea, setting up this in the question style format. So that way, that's how people think. When they look at documents, they don't think about, like an insurance document, they don't think about the term coverage is too abstract. What does that mean? What if my house burns down, if it's talking about a house? They think in terms of questions, and that's how you should set up your documents, in terms of this question and answer style format. So that was the idea. Well, I need drugs during the colonoscopy. What if I did not have the colonoscopy? That's something that's not required by law. But it doesn't take very long to put that in there, and it's something that should probably be in there, I think. Do I have other options? This is what I changed in the second version, explaining these options. I couldn't just put these terms down there: a rectal exam, a barium enema, a fecal blood test, a flexible sigmoidoscopy. Because again, what does that mean? It doesn't mean anything by itself. You have to kind of explain what that means. Otherwise, why even put it in the form? And then the risks. And with the risks, and this is where I've been learning a lot this morning as well. I'm thinking, what if right now we have common risks, and then uncommon risks, and then rare risks? So I was thinking, why don't we categorize the risks? But that kind of complied with what Yale was talking about earlier, is what if we went with most likely outcomes? And I have to think about this more. This is just my initial thought I wrote down on the paper. What if we went with the outcomes here? The worst case scenario, the best case scenario, the likely scenarios, instead of the risks like this. Well, at least on the education forms, that might be might be a way of doing that. But anyhow, so breaking out the risks, some things that are likely to happen, and then things that are not likely to happen. The two big things with colonoscopies are the bleeding and the perforation instead of, and I don't even know if I would put perforation in there. I'd just say a hole, but I put perforation and parens just for all of you. Now, and one of the other things, about icon arrays, you may know about icon arrays. I was trying to work an icon array into this 2-page document, but it just doesn't fit because of the 1 in 1,000. I could fit a 1 in 100, but not the 1 in 1,000 in there. But again, this is where I thought, well, I just don't want to list the numbers. If there's some other way that I could convey the risk, and I'm not sure this is the best way, but just I wanted that to be the point, is that thinking about it, instead of 1 in 1,000, what does that mean? Well, 999 people will not get a hole, and 1 person will get a hole. So it's just a different way of conveying the same information that might have an impact on other people, or at least a wider array of people. And then what can I expect after the colonoscopy? Again, not required by law, but that's what people care about the most. What's going to happen to me after this? Not only the major risks of getting a hole and excessive bleeding if a polyp is removed, but what kind of recovery is going to happen? What's going to happen to me? And so I think that's a good thing to put in the form, because it sets the expectations. I mean, obviously it should come up in other parts of this consent process, but just as a last-ditch effort into explaining what that is. And then the second side of the form is really where I think our biggest gains can be made. So on this side, it's patient's consent, and on this side, it's medical provider's acknowledgement of consent. So the teach back is kind of incorporated in on this side. So that would be the idea, is that during the initial intake process, when you're going through with the nurse and or the MAs or whatever it might be, you're reading and you are consenting perhaps at this late stage, because it's right before the procedure, perhaps it should be before any drugs were made. But you have to initial each spot, because again, it draws the eye, it makes you stop. I mean, you could just initial without reading, but there's not a whole lot I can do other than forcing you to read this to me. But anyhow, drawing the eye to each one. I understand what a colonoscopy is, and I know what it involves risks, including risks specific to me. I have been educated about these risks, and my provider has answered my questions about these risks. I understand the other treatment options available, all of that. And then on this side, the teach back, well, explain to me, my goal is this is where we need to teach our providers how to do this, that we're not trying to put them on the spot, that this is a mutual understanding. I don't want to do this unless you're fully aware of what's going on. And so you ask them what a colonoscopy is, why we're doing this for this particular patient, what are some of the risks we discussed, again, following up, do you have any questions for me? What are your other options? Might be another good question to put in there. And then what can you expect? Because that's the idea, is if we can kind of have the provider do this at the end of the process, not only does it help with patient understanding, but to selling it to our lawyers, it will help with litigation as well, because we have the patient's answers right here and the doctor's chicken scratch, right? So that's the idea. I think we can put things in there. And the other form basically just looks a little bit different on the front page. Let me see here. There we go. Same types of things. I just took out the specific risks and just had a general statement of the risks. Or the alternatives, I mean, yes, there are other options to a colonoscopy without explaining what they are. But it gives a little bit more white space, which I like a little bit better, and I don't have to put flexible sigmoidoscopy and all that in there. So it lowers the reading level, but the back is still the same other than just the line down here. So the idea is there's a lot of design options. So we think about the content and then we put the designs in there. But what I want you to understand is that we can cover our legal basis and use plain language and incorporate teach-back and probably produce more legal protection for all of our providers as well. So don't let lawyers tell you it can't be done. We can create this harmony. All right, that's I'll get off my...